Good afternoon. How's everyone doing today? It's really good to be here to discuss a very important and timely topic around inequalities in healthcare and different intersections on this critical issue where it's not only getting national attention, but global attention around the disproportionate impact of how folks in our community are treated, the different data, the different outcomes. We have a very esteemed panel here that will go through the different introductions, and then we'll go into secondly to some slides and some data just to get some teasers out there, and then we can go into some broader discussion. So with that, I'd like to turn it first over to Ms. Erica Hart to just introduce herself, her background, and then we'll go through each panel member, and then from there we'll get into the discussions.
Sure. Hi, everyone. Thank you for having me. My name is Erica Hart. My pronouns are she and they. I am a Black, queer, non-binary femme. I'm also a breast cancer survivor. You may or may not have seen me topless on the internet at some point. If you haven't, I could fix it for you, send you a photo. I am a sexuality educator. I have been teaching sex ed for the past 12 years now, with a focus on race, gender, pleasure, ability, and class, which is oftentimes missing in in any discourse, right? But especially in a sexuality education focus. So that's a little bit about me. And I'm in Brooklyn, and just to acknowledge the stolen land on Lenni Lenape, stolen territory, with my dog and my partner.
Excellent. Marianne, if you would like to go next, we'd love to, and then we'll to the gentleman.
Yes, Marianne Adams, deeply rooted in Atlanta, Georgia. And my pronouns are she and her. I sit at the fence line of public health, social work, and community activism. I've been doing this for 25 plus years. I've spent a lot of time in academia, but quit that to focus full time on building the capacity and the organizational development of Zami Nobla, the National Organization of Black Lesbians on Aging. We focus on Black lesbians over the age of 40, living anywhere in the country. We also have a state chapter in North Carolina. And for the past 15 years, my night job and my day job has been really doing community organizing, working with Dr. Tonya Poteet, who's been at Hopkins and who's now at UNC doing primary data collection, looking at breast cancer, COVID-19. And I am also, Erica, a 16-year breast cancer survivor. I've been living my diagnosis out loud, and I refer to myself as a breastless Amazon. So that's a little bit about me for now.
That's great. No, it's great to hear that those experiences and really connecting there with Ira. Would you like to go next, Mr. Baker? And Dimitri, last.
I'm sorry, which one of us did you ask to go?
Can you go next? Yes, please.
Oh, sure, yeah. Hi, I'm Araya. I am currently based in State College, Pennsylvania. No one knows where that is. That's central Pennsylvania between Pittsburgh and Philly, in the middle of nowhere. I'm here at Penn State. I'm doing research around mental health disparities in terms of access to counseling. I'm also a part-time instructor here for the master's program for the counseling and school counseling programs. And I've been a mental health advocate for like half my life, starting with personal experiences in my own life, my family. So I can't really say that it's work at this point. It's just like daily living out my purpose. And I think professionally, I've been connected with some organizations that have done a lot of impactful suicide prevention work. So that's a big passion of mine. And I try to always bring to mental health discourse a policy perspective. The idea that mental health disparities are not disconnected from voting for or voting against candidates that are putting forth a lot of exclusionary authoritarian policies that exploit and put, profit over people. And so we can't be out here talking about end mental health disparities without it's very politicized. We can't disconnect the two. So that's what I'm all about. That's what I write about, teach about, talk about, think about. Yeah.
That's awesome. Thank you for that. And Dimitri?
Hey everyone, thank you so much for this conversation. It's great to be here. My name is Dimitri. My pronouns are they, he. I am born and raised Queens, New York, also stolen land of the Lenape people. Araya, believe it or not, I have been to State College, Pennsylvania. I know, small world. So I am Deputy Organizing Director at Vogue, which is a healthcare-based voting rights organization. We explore the intersectionalities between health justice and democracy, working with health professionals, medical students, nurses, folks all over the country, helping really reach folks who need to get registered to vote, people who aren't really touched by the system, and really looking at how can we really think of ourselves as advocates outside the four walls of a doctor's office. And I come to this work as an advocate within the HIV/AIDS community. I started out my career actually studying theater, and I performed on Broadway and television for a little bit. And back in 2018, I made a decision to come out and share my HIV status on HIV Plus magazine. And I thought it would be the end of a lot for me, and it actually opened a door to allow me as a Black, queer, non-binary person to really stand up and say, yes, I am living with HIV, I'm thriving, I have a partner who loves me, I am worthy of love, I deserve love, and really standing here on behalf of our community to work and end the stigma and end the epidemic.
That's great. So these stories, and more importantly, your own personal experiences, I think is what's going to be very impactful in coming out to say, okay, this is who I am, this is how I want to impact change. And this is really about change, because there's a lot of gap in how we're treated in the healthcare setting. And you're saying we need to go beyond those four walls is something that I think will resonate with a lot of folks, so we can hear each other's story and hopefully make an impact that's so needed. We're going to share some data, and hopefully that can get us in the audience and all of us getting into some very daunting, unfortunately, in one of the largest economies in the world. We have some very disproportionate impact on Black, queer people and Black folks overall in terms of how we're treated in the healthcare setting and the outcomes. And I think, for both Mary and Erica, if you can share your experiences of, being in the healthcare system with the breast cancer, how that, how you viewed your experiences there as well could be something we'd love to hear about. Let's go to the next slide. And this is probably, it's very interesting, but it's accurate. 61% of African Americans with HIV are not receiving the benefits of innovative or advanced HIV treatment. We have some of this is like I said with other disease areas as well. But you in the cancer space, you have a very high cancer death rate amongst Blacks. 40% is because we're getting treatment and being diagnosed much later. And then with HIV clinical trials, where there's a very low participation trial rate. So there's just some of the areas where we're not being even treated on very innovative products that are out there that can help us have that data in some of these settings is lacking. Going to the next slide. 20% of African Americans live in poverty, and poverty increases onset of mental illness. Love to hear your opinion about this, Aria, around what you've seen out there in terms of, is there that correlation? High prevalence and only 2% of mental health professionals are Black, which is also a major issue whereby, not to say that, other mental health professionals cannot care for the Black community, but there's not that training there, or there's not a lot of incentives for current mental health professionals to increase the sort of that data set. I think we need more folks that come from different backgrounds to be able to treat and manage the population. And that's even where there is over, with 13% of the US population, and you still have this major gap in mental health professionals. And then the treatment gaps, as you know, are pervasive. So we talked about a little bit about suicide and major depression, where when you look at all the data and the stats, we're pretty high up there. And I think there's a direct correlation between not just the mental health professionals, but just the gaps in the standard of care that are not there. So love to, how do we really impact that? How can we? I don't think this is a panacea. There's a lot that needs to be done. There's just a lot of work based on these data sets that needs to be addressed. We touched a little bit upon this earlier, so we can probably go into the next slide in terms of, but the last slide here is the LGBTQ plus adults experience severe health barriers overall. And this is in addition to the fact that we have the racial component, 7% denied outright care from a doctor, which is totally unacceptable. And any doctor that would deny care to anyone, especially for gender or other basis, should be kicked out of the health insurance panel, right? It's like, that's the type of things that, people are hearing anecdotally, but it's really happening. 39% of new HIV diagnosed patients are from our population. 29% receive substandard or inappropriate care. 26% clinically depressed. 17% Medicaid, where there is really very lack of access to specialty. So if you're in a Medicaid plan or you're in a Medicaid program, it's very hard to go see a mental health specialist or cancer specialist or an oncologist or virologist, for example, and a higher risk of cancer, including breast and prostate. So I think there's a lot of optimism that now that health inequalities is at the forefront, where payers are saying, we want you to do better, we're gonna deny you payments. But then the clinical trials, we come from the pharma industry on this side, there's not a lot of us represented in those clinical trials, and therefore we're also not getting access to care. So hopefully this sort of gives us a sense of course, there's more to talk about from a policy perspective, from advocacy. But with that, I'd love to turn it over to the panel to chime in. Is there anything here you see that could be that from your perspective maybe can amend some of this data, or just get your thoughts on validating some of this as well? Please feel free, anyone. Dimitri, Marianne, love to hear your thoughts, and then we can go to.
I'll jump in with a quick thought. Seeing that percentage, 39% of Black LGBTQ adults who are newly diagnosed with HIV, that correlates with the current statistic that if HIV transmission rates continue, 1 in 2 Black, gay, or by identifying Black men will be diagnosed with HIV in their lifetimes. And that's a really harrowing thing to think about, to be a part of the healthcare system and to have been diagnosed and be, considered one of those statistics. And I think that one of the things that I have learned is the importance of having a healthcare provider who shares your experience, who can really understand you. I think of, when I was first diagnosed, I'm very lucky to have a primary care physician who is also a person of color, who is queer, and was able to really sit me down and help me understand what my next steps were going to be. When someone is diagnosed with HIV, there are so many things that need to happen. after that diagnosis. It's more than just, this is your diagnosis, good luck, I wish you the best, right? There are so many steps that need to be taken. And I don't know that we do a good enough job in helping folks navigate this system that is built and set up for us to fail, for us to want to say, well, this is too difficult. I'm not going to try and get medication. I'm not going to try and be treated. This is, it's too much for me. And so seeing that percentage up there on that slide, made me think of that. So those are just some of the top of mind thoughts I had.
Thank you. Erica, from a gender justice perspective, I know how do you weave that into some of the, the data in and of itself is the data, but there's some real critical issues that are continuing to create this gap, and to think that 50%, like you said, 1 in 2 may be further impacted by this is just insane to me. But I don't know, how do we activate some of these things, or is it possible, or how do we move the meter?
It's definitely possible. I think one thing before I answer the gender justice question is something that I've been thinking, well, when you showed the statistics, is a conversation around insurance and access to insurance, because there was one stat that said 77% of Black people have been denied care by a doctor. And I think that number is much higher in terms of being able to access doctors at all, because of our just oppressive structure around healthcare in this country. For example, when I was diagnosed with breast cancer, my oncologist said that I need to have 7 rounds of chemotherapy. And then my insurance company says, no, I think she should only have 5. Right. And I had to then fight that on social media, but then I think about, and was able to actually get the 7 rounds, but I think about the people that don't have any sort of social media, right? And don't have access to that, or don't know that these are all companies, right? And they don't actually have your best interests at heart. They're interested in making money, but to not have the access to actually fight that. But then the fact that we have to fight for our care is just so ridiculous, and just contributes to more horrible health outcomes, right? If we're stressed and we're just trying to get care, it's only going to make whatever sort of illness or disability that we are navigating worse, in addition to our mental health. And I think the gender aspect is that oftentimes we see non-binary and trans folks left out of these statistics, especially as it relates to cancer, but pretty much anything. Even when we're talking about voting, right? There's rarely a log of what non-binary folks are voting. What's the statistic there? How many Black trans people are voting? What is the impact on Black trans women? Black trans women have a life expectancy of 35. Right? How does that play a role in terms of health and health outcomes? And are they even included in these conversations? And rarely are they. Do I think that can shift? Absolutely. But I do think at even the research level, there has to be a dismantling of this idea that there's only 2 genders. There just has to be an understanding that there's so many more, and we have to be included in that research and then in the advocacy that follows.
Interesting. I definitely want to get back to this 7-course versus 5-course therapy, and how did you, how do you use that as a model for advocacy? Because that's the standard of care. But there's you had to fight that, and that's, a lot of people don't have that, the wherewithal or the like you said, the social presence to fight. So a lot of people could be getting substandard care just on those battles alone. Interesting. Araya, how you doing today? Mental health, as you know, is a critical component of everything we're talking about, especially, I know for me personally, it's a big issue in my family, in our community. And I think it also impacts, how a lot of us are raised in terms of our self-confidence and how we deal around other folks. I mean, to me, this is a major issue. I think it's like a massive public health not just a healthcare issue, but also from a standard of care, but also a public health issue. Love to hear your thoughts on some of the things on the data or other points we may not have raised.
Yeah, so several things came up. First, all of this is intergenerational. So like not only are we dealing with this in the moment, but like we're inheriting a lot of trauma around these same systems. Um, and then also I was thinking how when we talk about healthcare disparities, it's not just the trauma that one experiences in the institution or the system, it's also the trauma of living without any support. So it's like traumatic up until you get in the system, it's traumatic while you're in the system, then you get in the system and you're denied care or offered substandard care and you're funneled out of the system and it's still traumatic. So it's both the system that's traumatic, but the lack of it that's traumatic. Um, and then also thinking about my own experiences in my own work now, just how important it is to decolonize, because I think for a lot of these systems, they're run by institutions that are very much still their conceptualization of diversity is very much about representation. It's not about ideology. And so they might have recruitment programs to bring in more Black counselors, and they think that's enough, and more Black, doctors, and they think that's really doing something, but it's actually not giving what it's supposed to give because because you're recruiting people who are tokens and moving through the system, relating to clients or however you want to refer to service utilizers as sources of profit. And not only that, but they're often, and this is a big problem in counseling, often speaking to people as if people aren't the experts of their own experience. And so not realizing that healthcare is like a collaborative relationship. You're figuring things out with someone. You can go to school and learn all these theories, but at the end of the day, I go home and I deal with the symptoms or the condition. And there are a multitude of ways that's going to manifest that maybe I don't remember in the moment when I'm talking to a provider. And so you have to always center the client's needs. And I think that requires all of those mental shifts and those ideological shifts. I think the academy is responsible. I think major professional organizations are responsible. Think tanks and leading institutions are responsible. And then I know this wasn't a part of the panel, but before this, like Erica was talking about being a community educator, also realizing that there are people outside of these institutions doing the work better than people in the institutions who have all the credentials. So just because someone has a PhD or is a psychiatrist doesn't mean that they're more knowledgeable about these things than someone who has lived experience with the condition. And oftentimes, because we're going back to being intergenerationally traumatized, because we're so skeptical of these institutions, we actually need community educators and people with lived experience because they're the inroad. They're the people who are going to be able to go to the church or the meeting or whatever. And people are like, oh, okay, so this person, it's not their job. So they're not getting paid for this right now. They have no incentive to really like educate me in terms of public health. So let me listen. But we got to change our entire approach. And I think that is something that that comes up for me. And lastly, just remembering that intersectionality is not just stacking identities on top of each other, because that's a big thing that I hear in multicultural and social justice counseling courses. People having that frame is really much more about intersecting oppressions. So we can't talk about mental health without talking about food deserts and environmental injustice and housing policy, employment discrimination. That's what intersectionality really is, not just saying I'm this plus this plus this.
That's a very interesting concept. And I think, I don't know in my mind, and this is why I also need to be educated a lot as well, because I think we can learn from each other, is how do you disconnect the financial motives or leverage of financial motives to make change, right? Can you at all, like with clinical trials, right? Like with the pharma industry or with the hospital systems, can you say we're not going to reimburse you until you close the gaps in inequalities, right? I don't know, or is it, or this is also, and Marianne, maybe you can help me understand this as well from bringing the elderly community and others that have lived through a lot of this, is there, in addition to the policy and the advocacy, is there an ability for us to work with those institutions to drive change, or is such a tough road because the tokenism that they may put somebody in there, or they don't really reach out to the community organizer who may have more experience to help us bridge those gaps?
Well, I think the answer is both and. Certainly, and I'm happy you asked me that question, because I think it's important to bring into the space geography and class and elders. Queer elders are often left out of the conversation. We do know that there are 3 million LGBTQ elders above 65 currently in the United States, and that number is expected to rise to 6 million by 2030. And, that's a huge number of folk who are invisible and who are not often considered significant in our community. The queer community is very youth oriented. And we look at the fact that a lot of elders have really gone insular, they've gone inside, and we're losing, all of that experience and all of that, I think, information and knowledge, and that intergenerational co-mentoring that's so key to us, to our very survival, actually. I think it's both and, because we are a small grassroots organization who are conducting our own primary research. And since 2014, we have 3 data sets looking at, there's a dearth of information on Black lesbian elders when you look at the literature. And so we decided that we're not going to just sit here and beg and wait for these academicians to do the research on us. We have the skill set, we have the knowledge, we have the information, we can certainly, and we have a network, we can go do our own research. And so we've done research, mixed methods research, looking at Black lesbians and aging, looking at sexual minority women and breast cancer. And Erica has certainly helped us recruit those women for that. And we're currently looking at COVID-19, because if we don't do it, who's going to do it? And so I think that, and they're also, to specifically answer your question, we have been doing some practical grassroots shift changing work in our community here in Atlanta. We've actually renovated the first house for Black lesbian elders, called the Biggers House. One of our board members is leasing us a house for 35 years for $1 a month. We raised $100,000 on social media since 2017, and we renovated a 1,300 square foot house to provide safe, accessible, affordable housing. We have 5 community gardens in the backyard that the community comes together and we plant these gardens, and it's open to any LGBTQ person and people in the community, because this house is located in a working class Black community. And so we want to be good neighbors. We want to deconstruct the fact that we can do this ourselves. Food justice is essential to our very being. Having housing justice. I mean, if you don't have the basics, safe, affordable housing, food to eat, you can't go and do voter recruitment. You can't mobilize folks to vote because you're hungry. You have no place to live. Those are basic things that I think we can have some impact on. We've also started an organization called Malta, which is the Metro Atlanta Lesbian and Trans Housing Alliance here in Atlanta, with Transforming, which is a Black trans men and non-binary organization that focuses on Black trans families. And Trans Atlanta, which focuses on trans and non-binary folk writ large of all ages. because we felt like we were doing this housing justice work in silos, and we could leverage resources better by coming together and tapping our networks and tapping our resources and our information. And so we're doing those kinds of, we're creating some models so that people can actually say, we can start doing some of this work. We've always done this work. We've always done this work. And so to do it on a wider level, and the fact that we raised $100,000, we had zero when we got this house. We didn't know how to renovate a house. We had no money, none, but we've done it. And in September, we're going to have a seminar on how to renovate a house, looking at the good, the bad, and the ugly, because there have been a lot of good, some bad, and plenty of ugly. So we're going to show folks how to do that, because we can.
That's awesome. I'd say we're getting the lights, the audience on YouTube is very excited about this conversation. We have a couple of questions that we'd like to pose to the panel members. And Dimitri, you mentioned something earlier about you had a doctor that, and I don't know how many doctors you've gone through in your life, but you said you found one connected with. This question is from the audience, and when patients don't have a doctor that understands their experience, do we stand to be more successful, like teaching patients how to speak to the physician or teaching physicians how to listen? Love for you to start, and then we can go around to similar circle and with Erica, Raya, and then Marianne.
Yeah, that's a great question. And I saw something else come into the chat that I think correlates in terms of, being a patient advocate and what that means. And is that a good step for community education, for patient comfort, or nothing more than an insurance accommodation, which I think is a great question. That was one of the big things that I struggled with entering the patient advocacy space, because there is a degree of the work that I do that lives within institutionalized systems. And that's a really difficult thing. But then on the flip side, the fact that I get messages almost every day from folks around the world on social media who reach out to me and tell me that they've seen my story, and because of seeing my story, they're going to take one foot in front of the other to, I remember one day where I dropped everything I was doing. I was working on a show in New York, and a patient reached out to me, and the message, said, I saw your story and I was thinking of ending my life. And after seeing your story, seeing someone who looks like me, I'm hoping that you respond to this message. And I dropped everything I was doing that day and spent time with this person. And this was years ago. And now today, thankfully, we still keep in touch. And this person asks me about, okay, what is it like disclosing my status? Or I just met someone, I went on a date. And it's these interactions that I have in my life now that make me proud to be a patient advocate. And I do believe that it does help in community education. I think it brought me to where I'm at Vogue, coming in as a patient advocate and a community organizer in an organization full of brilliant doctors and minds. But now, getting to join their steering committees, I'm helping them fund federally qualified health centers, giving many grants to LGBTQ organizations in rural areas, in communities where folks living with HIV need this assistance. And so I think from a patient advocate perspective, I've been really blessed to be able to enter spaces that are historically oppressed and get to do what I am able to do in that space to help move the needle forward. So I do think that patient advocacy is really, really important for community education.
So in your sense, and I'd love to hear Erica's view as well, is that it's the patient definitely advocating for themselves, and then hopefully connecting with the right professional providers that can listen to them as well.
I think also it is it's your community. I wasn't able to find my provider had it not been for, I counted 5 people on my hand that I said I would disclose my status to. And one of those folks, a really dear friend of mine, connected me to my entire care team. And had it not been for that person, as opposed to the urgent care, giving me some papers and telling me, good luck, the first doctor we can get you to see is in 5 weeks, but you need to get on medication right away. having that community and being able to have that one person that I could reach out to and help me get to the right place. So community is everything.
Thank you. Erica? I don't know if you saw the question, the second part of the question, you can also delve into that. Thank you.
What's the second part of the question?
It was around yeah.
Okay. Yeah, I haven't had too much experience with patient advocates. Unfortunately, a lot of the care that I received has come from, like Dimitri said, from community. People telling me that this doctor is better than this one, or maybe you need to check out this person. But I do hate this idea that patients have to advocate for themselves. And people have told me that over and over, like, you just have to advocate for yourself. But when you are already completely freaked out by a cancer diagnosis, like, your head is already running in a lot of different directions to also have to advocate for yourself. And there's no cures for cancer at the moment. So it's an ongoing, the gift that keeps on going. So I'm always having to go to doctors' offices and have conversations with oncologists and nurses, and also front desk staff, right? Like, even just the greeting or the non-greeting when you walk into a doctor's office can completely throw you off if you're going to be able to advocate for yourself or not. Because sometimes I have to advocate for a hello, right? Just for a kind greeting, right? And then by the time I get to the doctor, I'm tired. So I don't ever want to push the idea that patients need to become doctors to actually get the care that they need. But I do think it's important that you understand that you have options, that you get to ask questions, that you shouldn't be rushed. A lot of doctors they're run by insurance companies. So they're who's next, 15-minute sessions with you, and then you need to get out. Make sure you take your time. If you need to go longer, stay in that room, right? But all of this stuff, I just want doctors to be more mindful of. I want the system to change rather than the onus being on the individual who's most vulnerable in that structure. Is my thing. And if patient advocates are doing that work, then great. I do think if it's funded by insurance, though, it could look kind of wonky at times. And I think that's perhaps why I've never seen a patient advocate in all of the navigating of the medical industry that I've done. I've never come across one per se. So yeah, I would hope that they would be more visible so patients don't feel like they have to advocate for themselves, and this idea that an individual would have to, in a whole system where people have gone to school for, I don't know, how long is medical school? 1 million years long, right? That they would actually be doing the care that needs to be given. But again, like Araya already said, care is political, right? So there's just lots of things happening and being taught in medical schools and not taught in medical schools that are harming patients. So I think the whole structure has to shift. The onus cannot be on a patient advocate, a patient, or just the one lone Black doctor, right? It has to be on a system actually being dismantled, and our medical systems are harmful. Like, that's it, right? The harm that is being caused within our medical systems and the erasure that happens to, social inequities that cause, poor health outcomes also doesn't work. So yeah, I hope that answers the question. I'm not sure if it is.
I think that's a great perspective. It shows that, and I think Araya is going to talk about, why the insurance companies and the economics of that, right? Because you mentioned earlier that there's some folks who know how to really advocate for the, or can really help the hospital system, the insurance system deal with these issues, but they're not the face. You use the word tokenism, which I think is, is appropriate in terms of, if you don't have the PhD or the MD or the MBA, or you don't have that, then they don't give you that credibility. So how do we give credibility to those folks that are more passionate about this and disconnected by the economics and just want to just improve outcomes? How do we do that, right? I love the idea, but it's just as Erica said, you go through medical school, 8 years, and it's just like, this is the person we think should be speaking for all of us.
Yeah, I think that I resonate with everything Erica said. First of all, I think for me, when it comes to like radically reimagining these institutions in society, there's like the very pragmatic part of me, and there's the very like systemic part of me. And so like the pragmatic part of me is like whatever can fill the void. Like if that's patient advocates, peer support, I'm all for it. But then the systemic part of me is feeling like what Erica was saying, like, well, why does the onus fall on people who are already stressed about having possibly a very stigmatized condition, and then also take into consideration like intergenerational trauma related to these systems? Why do they have to then take on self-advocacy? And so that part of me makes it clear that it's also a part of these institutions' responsibility to change their pedagogy, the way that they're training providers to view the power dynamic between themselves and the person who's utilizing the service. Because you can teach a patient all the advocacy skills in the world, but if you still have a provider who's gonna think that their authority is threatened and that that's a personal attack, well, then they're just going to funnel them into another system, or they're going to funnel them out of the system over something petty. And now that person doesn't have access to like dire services they need because they stepped on the wrong person's toes. And that's how callous a lot of providers are in the system. They don't care. You know, for them, they became a doctor or whatever because doctors are always going to be in demand. You know, like it's what their family wanted them to do. It didn't have anything to do with public health. And that's the same mentality for insurance companies. I can't speak to like insurance and other aspects of the medical field, but I know insurance companies hate therapists. They make it extremely hard for therapists to get paid. And so a lot of therapists will, you know, be super receptive to everything we're talking about. Like they want to be advocates for clients. They want to offer like pro bono services and services that are cheap and as accessible as possible. So they take on insurance, and the insurance is like, we'll pay you in like 3 months. And it's like, then you have therapists who can't pay their light bill and their rent, so they eventually burn out, and they're like, I can't do this insurance thing. I was just trying to help people, and now I can't even help myself. And so I think we really have to reimagine healthcare in general in terms of it not being about profit, but also the people who are making these pedagogies. And I know, who is that one doctor, Uche Blackstock? I don't know if y'all know her, but she's a Black doctor who has written very publicly about her traumatic experiences leaving. I think she was teaching, I don't want to get it wrong, she was teaching at NYU's medical school. And so there are a lot of academics like trying to change the training models for these healthcare programs, but they're also funneled out. So it's like, where do we start? And I know in my program, they're super open to teaching about the harm that the mental health field has done, from like drapetomania in 1851, fabricating all these diagnoses, from saying that enslaved Africans trying to get away were psychotic, to female hysteria in the early 20th century when women wanted to get divorces. That coincided with women getting the right to work. Then you have protest psychosis, psychiatrists literally fabricating a diagnosis again because of the civil rights movement. So every single time there's been a social movement, the mental health and psychiatric field has pushed back and weaponized diagnoses and institutionalization to undermine it. And so it's like, we're not doing it that bad these days, but we are still doing it because we're kicking the people who are trying to make changes out. And so I think that's also part of it.
Interesting. So Marianne, being from Atlanta and Morehouse and, medical school, and one question that came up on the chat is, do we know of any health systems out there or institutions out there that may be doing it right? And then I have an idea from this call, because some of you have gotten amazing care through your own community. You said you got a community referral. Maybe it's time to create a ranking database of the best providers out there that we've come across that do get it, right? And maybe post that as like as a model. I mean, I don't know. I mean, it's just an idea, but I know Marianne, one of the questions that came up, who's out there that we know? Because some people would fly anywhere or drive anywhere to get better health care outcomes, right? So I don't know from your experience.
Well, it's interesting that you should ask that question, because the first thing I thought about when you asked that was burnout. I mean, so we're going to have those one or two providers that do get it. And there's going to be a deluge of everybody. And this person actually, wants to help, needs to help. That's how they move. That's how they walk in the world. But again, we're creating another model where people are not taking care of themselves because they're trying to take care of everybody else, as opposed to, structurally, systemically train people to do what's right, to do what they should do to provide the best care and treatment for people. One of the things that certainly, and then when you talk about these health providers who do get it right, are we giving them what they need to be able to continue to do what they need to do and to train and arm people to do this work? There is also that. And these people leave the profession early because they have no more to give. They're totally depleted. So I think one of the things is to we've been talking about developing some kind of universal referral form that's virtual and in print, so that we can certainly make these referrals to people, because that's one of the issues with us. People always calling, I don't know where to go. I don't know who the health provider is. We're here in Georgia, where there is no Medicaid expansion. In many southern states, there is no Medicaid expansion. And according to the Williams Institute, most of the Black LGBTQ people live in the South. So they migrate to areas where there is a scarcity of any kind of decent medical care or treatment. And so one of the things that we've done is we've just really gone and we've asked Black LGBTQ people, what do you want? What do you need? And what Black LGBTQ women are telling us is that they want community connections. They want holistic and complementary care. Not so much the traditional medical model. That doesn't meet their needs. It doesn't work for them. Doing the three primary data sets we have, one of the most salient issues that emerges across these data sets are the need for holistic, complementary mental care. They want economic interventions. They want really accessible, age-appropriate information about services. Oftentimes, they are referred to healthcare providers that don't meet the unique needs that they have as older queer adults. They also want to have LGBTQ competent healthcare providers who have shared identities with them. They talk about wanting healthcare providers who look like them, who, if they don't look like them, at least they have a shared sexual identity or sexual orientation. And oftentimes they don't see that. When I moved to Atlanta in '88, and I went to a healthcare provider, and I was completing the intake form, and I saw the question, do you have sex with men, women, or both? I was shocked. I had never seen that question in my life. And I'd lived in Mississippi all of my life. But for somebody to see me, to not automatically assume that I'm heterosexual, that I live a heteronormative life, that I only have sex with men. I mean, I think that these are small things to some people, but they're huge to other people who feel like they're invisible, who are not represented and who never, ever have seen their identities. And we talk about a lot of rural queer folk who don't have access to even a fourth of the things that we have access to in Atlanta. But we're in Atlanta and they're still Georgia, you know. And a lot of people come here because they don't feel safe. They don't even feel safe going to a medical care provider, disclosing their sexual orientation or sexual identity. And we know that's an added layer. We have people who are so socially isolated that they don't even talk to another queer person for weeks and months. And a lot of people find it hard to believe, but it's the reality of the situation. We still have a lot of shame and stigma around certain medical issues that people believe is their responsibility, is their fault that they have a diagnosis of breast cancer or that they have a diagnosis of HIV. You know, we haven't talked about the church, religion, and what impact this plays in terms of the healthcare system. And so, you know, there's so many issues. And, you know, I'm thinking about the color purple, you know, we have to fight. All our lives we have to fight. And we talk about structural issues and they need to change, but what do we do in the meantime? You know, I mean, I've been on this earth 6 decades and we're still dealing with the same thing that we've been dealing with all of my life. So while we're waiting and fighting and challenging these systems, we still have to survive and live and thrive. And we have to help each other. And so some people actually prefer patient advocates. They want somebody they can trust, they feel safe with, they believe that has their best interests at heart. It's not going to kill them, quite frankly, because that's a reality for some people. You know, I don't trust what you're telling me to do because I think you're going to kill me. Because all my life, somebody's been trying to kill me because I'm Black, because I'm a woman, because I'm old, because I'm poor, because I live in the South. So I think, you know, it's not a simple answer. It's a multifactorial answer. And is there one place that I would refer people to that is no? Unfortunately, there is not. There are some very caring, loving, social justice healthcare providers who are, quite frankly, dying on the vine trying to help folk, but they're not enough.
Interesting. I know that there's this new industry that's both in the DEI space, right, where you have in the HR world of companies, they have, even in our company that I'm part of, we have a very strong DEI commitment. And now in healthcare, health systems are creating health equity officers, if you will, trying to get a hold of their own data in all the great research you're talking about to say, what can we use to try to integrate this into our workflow to hopefully stop this, or to it really has to stop, right? This data is out of control. That's my opinion. But more maybe their motto is, how do we curtail this these massive inequalities? So I know, Dimitri, is there one of the questions from the audience, is there a standing example model of maybe that it comes out of it, this HEI movement? And then there's another question that came out. Somebody mentioned a condition that started with D that rhymes with hysteria. I don't know, what was that? Can you just repeat that for the person on YouTube, and then we'll go into it?
That was drapetomania, and I actually fielded that answer to Megan, so she's going to give that to them.
Right. So Dimitri, this so you know, DI is a movement we think is making an impact. I know in my organization it has made a significant impact, because now, you know, the HR department and others have made this a strong commitment, recruiting, but more importantly, retaining, which is the toughest part. Do you see HEI, or, you know, health equity officers or health equity movement, which is in parallel with this, going to try to tackle this data? Because I think I'm trying to remain optimistic here as well. So is that going to be the gateway to tackling some of these issues, or is there something else we can think of?
How much time do we have? No. I mean, I think at the end of the day, we just need free and universal access to healthcare. And I think that that's just, what it is. Like I think about Denmark, and Denmark, while homogenous, yes, because of their free healthcare system, the life expectancy has grown almost 4 years and from 2005 to 2015. I think that institutions and organizations need to work with folks like Araya, folks like Erica, folks like Marianne, folks like me, and they cannot expect that they're going to be able to do all the work themselves within their institution because they don't have all the answers. Marianne is just dropping gem after gem after gem after gem. And this is what institutions need. This is what health equity officers need. I'm quite frankly tired of sitting in diversity sessions and listening to data and like reliving our trauma and then talking about the trauma that I have as a Black, like I'm tired of it, right? And like we know what the answers are, we know what to do, so we need to just get up and do it, and not sit on our, booties and make a check, right? Like we need to actually include community organizations. When we talk about holistic and community care, we know what that is. Institutions know what that is. Why are we so scared to just do it?
Yeah, Erica, I'd love to hear your thought about, this, how do we bridge that, right? It's the HEI officers, I think they're going to keep looking at this data, but are they going to be able to, how do we bring all of us into the debate and action against that? And I apologize, I started with data because I know this is like, we're all tired of it. But yeah, it's daunting. So love to hear your thought about that as well.
I think and people always get upset with me when I say this, but I think it's interesting, is that DEI offices and health, what did you call it? Health equity
offices, yeah.
Equity, all of those things need to want to go away, right? Like their jobs need to actually dissolve. And people get so upset, like, what? I don't want to lose my job, or I don't want the job to go away. It's like, okay, so you care more about the job than what you're there to actually undo. Because if you are there to undo, white supremacist, capitalist patriarchy, rest in peace, bell hooks, then you don't have a job anymore. And that's fantastic. You get to do something else. But I think the desire is to keep having these positions so that these institutions, like Araya already said, can tokenize a particular person so that they can, wash their hands of being anti-Black and not dealing with the foundation of anti-Blackness, which is all of our medical institutions, by saying, look, this Black person, which I know they're Black, is working as the health, equity resource person. Look, we have this person now, it's all good, like that doesn't work, right? And I feel that is what people are, what institutions are doing in replace of actually, like Dimitri said, taking the action that needs to be taken. Yeah, I don't know. I feel like that's all I got. Like, I really want to see the end of this. I want to return to African Indigenous modalities of care, like I don't want that to be shunned. I go to a Chinese medicine practitioner once a week and my doctors have all laughed at it. Literally all of my Western doctors have laughed at me going to an acupuncturist, a form of medicine that have existed longer than Western medicine. Like, who are you to laugh at this, right? But that integration, I think, needs to happen. And I think eventually Western medicine needs to be brought down several notches of the care that it oftentimes does not actually provide. I think the truth has to be told about these institutions. A really, really phenomenal, necessary book that anybody who's working in these fields needs is Medical Apartheid by Harriet A. Washington. And it is a challenging read, but so many people in medical spaces, even in social work spaces, do not understand the harm that has been caused. They may come into it like, oh, I want to make a difference, or with a power trip and wanting to, have some sort of control over people's bodies and denial of their autonomy. And they are honestly in the right field because that's how it's been built, right? It's been built over literally stealing autonomy from people, especially indigenous, African enslaved people, to say, look at how powerful we are. Look at all the medicine that white people get to have access to. And I can't say that that has changed all that much, which is why we're looking at the data that you showed in the beginning of this, is that our medical institutions, they may look prettier now, but they haven't really shifted in terms of the racist, classist foundation that they started from.
Well, I would definitely, with this very esteemed panel, more importantly, very honest and open discussion that we had, and that we will continue to have, I believe that this, through our energy, into our advocacy, that we're going to make this change, and hopefully others are listening, and especially those that are maybe inadvertently and like you said, in a lot of cases, advertently creating these barriers, can hear us and work and partner with us to make these changes. I do have to say that some governmental entities, including in North Carolina and even CMS, are creating new quality measures, as well as creating payment schemes to try to steer these health systems to close these gaps. But you're absolutely correct. It's not enough. I think working, what Dimitri said, working with all of us in a collective fashion. As a matter of fact, the health equity officers, all of them should have you guys on their advisory board and should be speaking to you, the four of you, on a daily basis. So
they have to pay us a lot of money.
I was gonna say, is it paid or
the owners of the hospitals make?
Absolutely.
In full disclosure, my wife she's going to be the health equity officer of one of these institutions. She's a physician, and I will make sure that she connects with all of you, and I think she'll be very well served. And they do have money, and they should pay. I agree with that. Well, thank you so very much for your time. This was, for me, a blessing and an honor to be. I've learned a lot myself, and I hope the audience as well. Thank you to the Omnicom and others and everyone for this great discussion. Have a great one. Thank you.
Thank you.